Thanks. First of all, I'd like to thank the organizer for inviting us. And today's my talk is going to focus on the quest for checkpoint inhibitor biomarkers. I didn't prepare much introduction for checkpoint inhibitor because I assumed that there will be talks before my talk to discuss about checkpoint inhibitor. But I guess even without that introduction, everybody knows that immunocheckpoint inhibitor is the most exciting development in the recent year in the oncology field. And so we know that for the immunotherapy, particularly for the checkpoint inhibitor to work, it is due to the immunity cycle that cancer antigens released by dying cancer cells actually trigger the immunity cycle. And because at the local environment, cancer cells actually try to protect themselves by releasing or using a lot of checkpoints to escape the immune surveillance. So checkpoint inhibitor, by acting at this environment to release the immune suppression, would restore the immune surveillance and allow T cells to attack tumor cells. And that's the fundamental of checkpoint inhibitor and the efficacy. So these are the drugs that are designed to restore immune response to kill tumor cells. And currently, there already have 6 checkpoint inhibitors approved by US FDA. And currently, more than 1,000 combination trials are ongoing to combine the checkpoint inhibitor with other treatment regimen to treat all kinds of different conditions. So these are the approved checkpoint inhibitor. I forgot to put in another one. So we have one CTLA-4 blockade, and then a couple of drugs working on the PD-1, PD-L1 axis. And so they're mainly acting at this local immunity synapse. And if we look at the efficacy of checkpoint inhibitor, no wonder we are so excited because this is actually one class of drug that have efficacy across many different cancer types. But some of the patients actually will also derive long-term benefit. The only problem is that even though durable tumor regression can be seen in some patients, but the percentage of patients that shows durable response varies quite a lot from cancer to cancer. And so you can see that for myeloma, in some study, you have close to 50% of patients showing really good response. Yet some cancer type, you have really low response rate. So obviously, biomarker is needed to identify who's going to benefit from this kind of treatment. And also, so there are 2 different strategies. The first strategy is if we can combine immunotherapy checkpoint inhibitor with other treatment regimen, then there's a possibility to increase the ratio of the patient who experience durable response. And the other possibility is that if we can at least more accurately and more sensitively identify patients who respond, then we can also increase the ratio of patients who benefit from this kind of treatment. And so obviously, biomarker is needed for this class of drug. And when it comes to biomarker, as the biomarker that we are familiar with before, that, for example, for patients who would respond to EGFR TKI inhibitor, you look at the EGFR status. And so similarly, most of the strategies that have been used before for targeted therapy and for biomarker associated target therapies to look at the drug target. So no wonder the first biomarker that have been evaluated for checkpoint inhibitor is expression level of the drug target, which is PD-1, PD-L1. And so this is the first biomarker that have been tested. And I think this is quite reasonable because PD-L1 is definitely overexpressed in majority of tumor tissues, but at different fraction. But you can see that majority of cancer type actually express PD-L1. But when it comes to practice, when we begin to use PD-L1 IHC as the biomarker, then there comes a lot of problem because we know that PD-L1 is a dynamic marker. So its expression level varies within the tumor, varies at different stage. And also this PD-L1 expression can be observed not only in tumor cell, but also in immune cells. So when we decide to use biomarker, particularly PD-L1 standing as the biomarker, then there are a lot of questions associated with it. What type of cells should be investigated? And also, right now, there are so many different IHC tests for PD-L1. And so these are the 4 different drugs that have been approved. And you can see that they use different antibody. They look at different staining pattern, and they have different cutoff. So, and of course, this is the result that we see for the overall response rate. So some of this PD-L1 IHC has already been approved as companion diagnostic. Others are approved as complement test for individual drug. That means oncologists, when decide to use the drug, before they decide to use which test, they have to decide on which drug to use. So this is right now is not, there's no single test, PD-L1 IHC, there's no single test that can be applied before the doctor chooses the drug. And also there's some problem with PD-L1 expression. If we look at the efficacy or the predictivity of PD-L1 IHC, then we compare the response rate with or without PD-L1 stratification. You can see that in some tumor types, pretreatment PD-L1 expression actually correlate with the response rate. But even with PD-L1 IHC, you can see that the positive response rate would not go over to go above 50% except for this particular trial. And for other cancer type, for example, squamous cell lung cancer, expression level of PD-L1 doesn't correlate with the response to PD-L1 inhibitor at all. So this means that even though this is the first marker and at this moment is the only approved marker, but the marker is not good enough. So we definitely need some other markers to assist to identify patients. So that comes to the second part of the talk. Today I'm going to focus on the mutation and also checkpoint inhibitor response. We all know that the reason that immunotherapy works so well for cancer is that cancer is a disease of mutation. So immunotherapy actually attacks the heart of carcinogenesis, which is mutation. So as tumor continues to mutate, the immunotherapy can still adapt to the mutation and also with sufficient specificity. So how does this specificity come from? Actually, in addition to the recognition between checkpoint molecule, in order for the T cell signaling to be activated, the first step is the recognition of T cell and tumor cells. And how does tumor cell recognize T cell? How does T cell recognize tumor cell? T cell recognize tumor cells by the specific antigen presented on the tumor cell surface. And this is what we call neoantigen. And so the theory goes, and also a lot of data have already shown that tumor cells has a lot of mutated proteins, and those mutated proteins, once being degraded by proteasome, will produce mutated peptide, which can be loaded on the tumor cell surface by the MHC class molecule. And then tumor cell, T cell has a TCR, which can recognize these mutated markers on tumor cells, and then initiate the attack. And so this is the essential step. Doesn't matter which checkpoint inhibitor you're talking about. And so if, so we can it mentioned that for any tumor cells that has more mutation, then there will be more mutated peptides and neoantigen on tumor cell surface. And so this particular tumor cell will be more likely to be the target and be attracted by tumor cells, by T cells. And so if we can measure the mutation burden of the tumor cells, then we ought to be able to predict or at least identify those tumors with more mutation. Those will be the target of immune cells. And so in order to measure the mutation, right now there are a couple of methods, and I'm gonna discuss between MSI test and also mutation burden. And as we predicted, if you look at the tumor mutation burden and response to PD-L1 blockade, on the x-axis, you can see that the mutation per genome. And you can see that for most of the cancer type with low mutation per genome, their response rate to checkpoint inhibitor is actually much lower compared to those tumor types that has higher mutation burden. For example, any tumor that has more than 1,000 or close to 10,000 mutation per genome, they tend to respond quite well. And if we look at those tumors with high mutation burden, then those are the tumors that has deficiency in the mismatch repair system. So let's look at the monoallelic and also biallelic tumor that has mutation on mismatch repair. And this is the data that was published on 2015, clearly showed that tumor cell that has mismatch repair deficiency show excellent response to checkpoint inhibitor. And so you can see that a lot of tumor that has mutation or deficiency on mismatch repair system, they tend to respond not just deep, but also with durable response to checkpoint inhibitor. So obviously, this is a very good marker to identify patients who are likely to respond to checkpoint inhibitor. And actually, based on that result, even though it's not a very large trial, but based on this result, US FDA actually granted approval for Keytruda to treat adult or pediatric patients with cancer that has microsatellite instability high or mismatch repair deficiency. So now we are beginning to see that an approval that carry just biomarker, no specific tumor type. And so this is the first pan-cancer approval. And when we look at the mismatch repair deficiency in different cancer types, then obviously colorectal cancer is one of the cancer types that we expect to see a lot of patients that has mismatch repair. And indeed, this is the data that showing that about 15% of patients with colorectal cancer will have MSI high phenotype. And so initially, this actually generate a lot of excitement. But if we look at the data more closely, then you will find that only patients who are at earlier stage who will have more MSI mutation. For those advanced stage patients, for example, colorectal cancer patient, the percentage of MSI high patient in stage 4 cancer is much lower. And this is actually not as low as we expected. In our experience, we only see about 2% of patients with advanced stage colorectal cancer. So this is a good marker. The only problem is that it has very low detection rate. So let's go back and take a look at other mechanisms. We are talking about the real mutation count. So in 2014 and 2015, there are 2 consecutive papers published talking about non-synonymous mutation burden in solid tumor. And in particular, these are 2 studies, one focused on myeloma, the other one on non-small cell lung cancer. And each use a different checkpoint inhibitor. anti-CTLA4 and PD1 blockade. Both studies shows that for those patients who has higher mutation burden, higher tumor mutation burden, they tend to respond better to checkpoint inhibitor. And so we are talking about a study that you take the patient's tumor and conduct whole exome sequence, and then count the somatic mutation number. And for those patients who has higher mutation burden, they tend to have better response. This is great, and also fit the hypothesis behind checkpoint inhibitor mechanism. The only problem is that whole exome sequence for a lot of patients is really difficult, and also this study is very time-consuming and also very expensive. So even though it is a very good marker, but to take it into clinical practice will be kind of difficult. So scientists begin to think about, is it possible to use a smaller panel instead of whole exome sequence to also predict the tumor mutation burden and still use that to predict patients' response? So this is the publication just published this year on Genome Medicine. So these are a study compiled about 100,000 human cancer genome data to see whether just by using a smaller panel, we are talking about a panel that sequence 200 to 300 genes, can show a good correlation to the mutation burden predicted by whole exome sequence. And as you can see, this is the data calculated from whole exome sequence. This is the data predicted by a smaller panel of about 300 genes. And you see a very good correlation between whole exome and targeted sequencing. And also, the second question is that whether the panel sequence have good enough reproducibility. So this is a comparison of the same sample using two replicate of targeted sequencing. And it also shows pretty good correlation. So we know that using smaller panel instead of whole exome, you can still accurately predict mutation burden. But how accurate is it? So they also, using the panel sequence and compare those patients with high mutation burden. So these are patients with more than 100 mutation per megabase versus those patients with lower mutation or even just 10 mutation per megabase. And then compare the predictive data versus whole exome data. And you can see that for those patients with high mutation burden, this data has really good predictive power. For those patients with low mutation burden, then the whole exome data is much better. The panel sequencing has a lot of variability. And also it depends on how wide the range of chromosome you cover. If you just sample a very small fraction of genome, so say you sequence 50 genes, cover only about 250 kb of genome, then you have a pretty wide variation. But if you can expand the sequencing region up to at least 1 megabase, then you get pretty good predictivity. So in order to use smaller panel to predict to estimate tumor mutation burden, this sequence region has to be large enough. So at least 1 megabase in size. And also because we know that microsatellite instability high is a surrogate for mutation burden. So they also look at the data between, I think the background didn't show up, or the total data is too light. But they also compare the relationship between TMB and MSI. So they found that most of the patient who has mutation high, tumor mutation burden high, they also have some MSI status, but they do not have a complete overlap. And there's also a group of patients who has very high tumor mutation burden, but didn't have MSI high status. So it seems like to sensitively identify those patients who would respond, you need to combine these two, particularly for example, for endometrial cancer patients, there are a group of patients who actually are MSI high but doesn't have high mutation burden. So these two should be combined to get the better predictive power. So based on those data, there are currently a few tests already available in the market. So for example, Foundation Medicine used their Foundation 1 to measure the mutation burden, and they set the cutoff about 20 mutation per megabase, and their panel cover about 1 megabase of genome. They use this to select patients who are likely to respond to checkpoint inhibitor. And another panel offered by Caris Life Science, they also use similar approach, but instead of going through a more thorough evaluation, they set the criteria at 17 mutation per megabase, because this is the number where it shows the good differentiation between MSI high and MSI stable patient. So this is the cutoff they use. But if we look at the data, then we know that just by counting the mutation is not enough. If that's enough, then how come you would see that patient with mismatch repair deficiency still don't respond? So obviously there are some factors that contribute to the resistance, and similar results are seen in every trial. So what contributes to the resistance? This recent publication on Nature Communication actually provide a very good evidence that resistance to checkpoint blockade primarily through the inactivation of antigen presentation machinery. So this is one patient who initially responsive to ipilimumab, later on developed resistance, and then changed to pembro. So you can look at the patient's mutation. Before the relapse, patient has about 248 mutation. And after the patient developed resistance, still pretty high number of mutations. So obviously patient didn't become resistant because of losing any mutation. But when they look at the mutation pattern, they found that when the patient developed resistance, the patient actually begin to see B2M mutation. One beta-2 microglobulin mutation begin to show up, and the other allele of the wild type actually begin to lose. So this is a combination of mutation plus loss of wild type B2M that confer the resistance. And this is not just the acquired resistance. Actually, these are initially 3 non-responder from one of the data set. They analyzed those non-responder, and in each of the responder, they found B2M mutation in one allele, and the other allele was lost. So for those patients who doesn't have functional antigen presentation machinery, they tend not to respond. And so this is another data also show that if you use CRISPR to knock out every genes in the genome to identify which genes is essential for immunotherapy to take effect, then the most important genes are antigen presentation machinery. So those genes involved in MHC complex, those genes involved in degrading proteins, and also those genes involved in transporting this degraded peptide into ER. All of these genes are essential. And so now we have much better idea on what contributes to the resistance. So in order to identify those patients who are likely to respond, you not only have to look at the positive predictor, which is high mutation burden, you also have to look at the negative predictor. So those patients with deficiency in antigen presentation machinery, they should be excluded. And of course, we also know that there are a small group of patients who tend to show hyperprogression upon the checkpoint inhibitor treatment. Right now, the genetic alteration responsible for this kind of adverse response is not clear yet, but we believe that more data will come up. And then this genetic alteration should be taken into consideration even more seriously. And so the final excitement about this tumor mutation burden is that you begin to hear that instead of using tumor tissue, there are also assays coming out saying that you can estimate tumor mutation burden using liquid biopsy. So just by sequencing patients' sample, blood sample, you'll be able to estimate and identify who is more likely to respond. But I think there's a word of caution about liquid biopsy for tumor mutation burden, because we know that it's promising, but the data doesn't look as good as the tissue data. And also because this sequence tend to have very limited scope, so the predicting power is much lower. And liquid biopsy has intrinsic limitation for a certain tumor type. And also it is not very sensitive, particularly at early stage, for early stage cancer. And finally, it has very little or no chance to identify biallelic inactivation of beta-2 microglobulin or other essential genes. And then draw to the conclusion on this slide. So there are a couple of biomarkers. Some are already approved. So for example, PD-L1 staining, it's companion diagnostic for some indication, complementary for others. The only problem is that assay standardization is still a problem. In terms of genomic marker, MSI analysis to identify mismatch repair deficiency patient is also very well established and widely accepted. So you can either use IHC or PCR-based analysis, or you can sequence those genes involved in mismatch repairment. So it's standardized assay. The only problem is that it has pretty low positive rate because in advanced cancer, so we obviously need additional method. And so currently, I think the most promising and also it's going to be the future of checkpoint inhibitor biomarker will be sequencing using panel sequence. So we typically will target 300, 400 genes to cover enough of genome, and then estimate the mutation number, and then identify those patients with high mutation burden. But one word of caution is that mutation count and mutation content are equally important. So for those patients who has high mutation burden, you have to make sure that the patient's mutation doesn't include mutation on antigen presentation machinery. And then finally, I think the excitement about liquid biopsy to calculate or to estimate tumor mutation burden is promising, but we do have to be aware of the limitation. This is actually what most of the company are still working on, is the assay to characterize tumor microenvironment, so we would know whether there are immune cells in the tumor microenvironment and whether there are additional checkpoints present there. So this is going to be the future, but we expect to see some really useful data coming out pretty soon. Thanks.